job. All right, so up next we have Stuart Campbell, and he's being represented. No? Sorry, Kenneth, go ahead. Kenneth Skinner.
Good afternoon, everyone. Today I'll present on rescuing the 30% of heart failure patients who have run out of options. We're developing a first-in-class dual mechanism cardiorenal. Can you hear me? Yeah, okay, good. So we're developing a first-in-class dual mechanism cardiorenal rescue. We're currently amid a $30 billion crisis. ADHF, or acute decompensated heart failure, is the leading cause of hospitalizations over 65 years old. Currently, there's about a 25% 30-day readmission rate, leading to massive Medicare fines. Currently, these options don't work. And really, this is driven by low cardiac output that drives diuretic resistance. And actually, 30% of patients are actually resistant to diuretics. They actually just don't work. These patients are also given contractile agents that try to force calcium contractions, and the heart simply doesn't respond. These patients undergo a renal lock where that low cardiac output causes kidney hypoperfusion. We've developed a small molecule that actually uniquely breaks this lock via a dual mechanism, direct cardiac activation and a renal enzyme inhibition without calcium toxicity. Our compound is a relaxation-safe cardiac activator without the calcium toxicity. We actually demonstrate that we developed a first-in-class cardiac activator with a sarcomeric target and also leads to natural uresis via the urine and a targeted vasodilator. So we're not only acting at the cardiac level, but also at the renal level. And again, this is at nanomolar concentrations that we actually have a first-in-class dual mechanism molecule. For the competitive landscape, we are highly differentiated. For one, we show that we generate increased peak force with our molecule, reduce time to peak force, so faster kinetics, and we preserve relaxation. That's key because if the heart can't relax, it can't actually rest and refill with blood to actually pump blood. Further, we lead to a microvascular vasodilation, which leads to that renal unlocking. Here I'm showing that actually our compound actually at nanomolar concentrations drives a punch with snap, meaning we increase the peak force and we also lead to a faster time to peak force. And this is actually validated in 3D human engineered heart tissues commissioned at our local Yale spinout, actually by Stuart Campbell Propria. So we actually show about a 13% increase in peak contractile force, which is a Goldilocks zone, because actually that 13% increase is actually a clinically meaningful benefit. Further, we show a rapid rise, meaning that we not only increase the force, but actually the heart actually generates that force in a much slower amount of time, which is key because the heart is already so stressed. And we do this with no relaxation cost. We need these direct cardiac muscle activators like YBF1. As shown by the market, BMS acquiring myocardia, and actually just today, Cardigan literally just announced that they're IPOing for these types of direct cardiac muscle activators, but not with this profile. We actually show improved contraction force, reduced time to peak force, and preserve diastolic relaxation. Again, this is key because other drugs prolong the systole. The heart doesn't have enough time to relax. We're actually increasing the biomechanical mechanics of the heart. Faster systole leads to actually that diastolic sparing zone so the actual heart can actually relax and get ready for the next cycle. Our compound actually targets blockbuster markets and orphan drug designation. We actually have validated phase 2 efficacy biomarkers for diuretic-resistant ADHF. For one, our primary marker is actually urinary sodium, right? And that gets to that natural uresis mechanism that I mentioned, where we can actually prove that our compound actually breaks that resistance in patients. This is an actual urine biomarker. Our secondary is actually urine output. By showing we increase urine volume, that's actually showing target engagement within the kidney. Further exploratory hemodynamics, direct catheterization readouts. And we're not just limited by ADHF, we also have ways to go into orphan indications markers as well that actually require the same exact mechanism. So I like to think that we're actually generating the triple crown in human engineered heart tissues by not only using chemistry and AI-driven optimization with Victor Batista, but also with functional human engineered heart tissues with Stuart Campbell. And we actually have provisional patents filed by Yale in progress, covering not only the AI methods, but also the molecule itself. we are asking for a 30K accelerator to prime our ADME tox and our target engagement markers. I would like to highlight that our compound actually has high intrinsic solubility and nanomolar potency, yielding a massive solubility safety margin, enabling a direct-to-saline formulation for the ICU. We're asking for 10K for ADME tox. This actually feeds into our life cycle strategy for not only IV, but also home oral, and also stability assays and HERG safety screening. We're actually asking for the majority, 20K, for a single dose IV PK that gets into those urinary efficacy markers. And I want to highlight our capital efficiency because we're actually able to, within those same samples, measure a targeted urinary metabolite showing our renal inhibition at nanomolar concentrations. And all this data is fundamentally feeding into our September SBIR. Thank you.
Questions from our judges?
Hi, this is Christina Forbes with Abbey Ventures. Can you tell us a little bit more about the patient journey and how you envision administration, either in the hospital or at home setting? Of course, a little bit outside of the scope of where you're currently at and what you're trying to achieve with the funds, but I'm curious to learn a little bit more how you're thinking about that.
Yes, that's a great question. So we're working with actually a clinical physiologist and and so the goal is to, for one, have an ICU patient. Oftentimes these patients are the sickest patients. They're already actually hooked up to certain catheters and will catheterization. And so actually we can have this molecule actually be an IV formulation, which is actually why it's key to have that high intrinsic solubility, that rapid onset, and also that safety screening that we're also seeing in our human heart tissues, and we're also further validating. And in terms of the home oral, with the funding, we'll actually be able to get a handle on the PK of the molecule as well, because that'll help us to understand what the actual half-life is, because with the ICU, we want to actually have titratability, right? And so that'll give us the PK in order to understand how to formulate this molecule and within that time frame. And so with the home oral, that will allow us to really expand into the market. And there's precedent for that, by the way, with compounds that are unfortunately toxic.
Is the target in the kidney? You mentioned an enzyme, but what's the mechanism there?
For sure, yeah. With this being I can broadly say that it targets a renal enzyme that actually is very important for anti-inflammatory and vasodilation with a validated urinary biomarker.
Could you take us back to slide 4 for a minute?
Let's just do this. Can you put on? Oh, hey, AV, can you put it to slide 4?
Oh,
So,
the previous presentation, please.
Yeah.
Yeah, slide 4, I was looking at your data, and the magnitude of the changes looked very slight to me, and I didn't see any statistical significance on the endpoints, and the number of the sample size is extremely small. I'm curious as to your thoughts about the magnitude of that effect relative to the interpretation.
Great question. And honestly, like the answer to that is like, for the contractile force, we're not looking for a massive increase. Actually, if you look at these inotropes like dobutamine, they're leading to 50+%. Like they're literally starving the heart of already massive oxygen demand. With that 13% actually increase in contractile force, that's actually, and we've been speaking with clinical physiologists that will ultimately need to be confirmed in vivo, that's actually a zone to be actually able to generate ultimately a cardiac output of milliliters per minute, a half a liter per minute that can actually be perfused. And so in terms of the actual time to peak force reduction, that is significant, because if you compare competitor molecules, they actually lead to a 50% increase in the time to peak force due to that prolongation. And so we're actually reducing the time to peak force, and so that's about a 50% differential.
But isn't that magnitude of the overlap there